Kommen wir jetzt zur Keynote Lecture und ich darf Frau Professor Leubel bitten, einzuführen.
Ja, ich freue mich ganz besonders. I'll take the pleasure to announce our keynote speaker. It's Professor Masakazu Choi. He took a long trip to come from Japan to Germany, and I think it's a pleasure. We have close collaborations also with the Japanese colleagues. And Professor Choi graduated in 1982 from Hiroshima University School of Medicine with his medical doctorate, and in 1988 with his PhD. He studied also at the Institute of Molecular Medicine at Oxford University from 1990 to 1992. In 2007, Professor Choi was appointed Professor of Breast Surgery at the Graduate School of Medicine in Kyoto University, and also the director of the breast cancer unit at Kyoto University Hospital. He is passionate about his study of cancer, particularly breast cancer biology and treatment, and he also very keen on research that translate basic science into clinical studies. He's involved in various innovative research projects on the development of new anti-cancer diagnostics and therapeutics, including biomarkers, novel imaging, and antibody treatment. He is engaged in many clinical trials, mainly associated with breast cancer treatment and research, and he has a strong interest in the tumor microenvironment, such as angiogenesis and stromal reactions. Professor Choi belongs to various associations and is a member of several leading academic organizations, and he served and still serves on editorial boards of various academic journals, and he has co-authored more than 300 articles. I welcome Professor Masakazu Choi from Japan, and he will give to us his keynote lecture. Thank you.
Thank you very much. The kind introduction, the hospitality. I'm very happy to be here. And I worked together with the GBG-ASM, is that right? For many years, actually, in global trials. Today, I'd like to touch on this topic, the innovative research project. It's a huge task, driven by the CBO. The CBO, mentioned about my record, but too much actually. I don't know who wrote it. Anyhow, this is my show. Today's agenda, I'd like to talk on these topics. And this is a very general view of what happened in major diseases in Japan. Cancer statistics 2022. You can identify how the malignancy is still increasing. And also we know that how the disease status and the cardiac disease and stroke are somehow stable now. This is the breast cancer age-specific patterns in Japanese female. The blue is breast, and the peak is around the 50s. It's very different from that, the age-specific patterns in Europe, maybe Germany, and also from the United States. You have the just a straightforward increase by age, but in Japan, it changes to plateau around 50. More or less, the Asian countries would have similar patterns. I don't know why. Some epidemiologists, they suggest that we will catch up soon. Or the Japanese Asian food, Asian lifestyle may be preventive, and particularly postmenopausal, the breast cancer. Premenopausal breast cancer are almost the same as yours. And this is the size detected tumors, sizable detected tumors, and the left-hand side is symptomatic. Roughly 50% of the cases are detected stage 0 or stage 1. That means the stage 2, stage 3, still quite a lot, 50% of symptomatic detected tumors. Screen detected, they totally different. 75% of the cases, stage 0 or stage 1. And this is a situation of Japan, the JBCS registry. But I don't know why this happens. In terms of the nodal status of detected tumors, it's not changed at all for these over 15 years' time. Nodal positive rate is very constant for 15 years' time. It's a curiosity to me. And you discussed a lot on the local treatment this morning. This is just one issue from Japan. A Japanese agency, PMDA, quite recently in December approved indication of this radiofrequency ablation for breast cancer. As you know, it was approved for liver cancer treatment, but now they got the approval for breast cancer non-surgical ablation. The indication criteria should be less than 15 millimeter, 1.5 centimeter, and well localized, obviously, and luminal air-like and node negativity clinically. And the right-hand side, it's a typical one case, a single case, who treated by the radiofrequency ablation, non-surgical. The last March, we discussed in the Kyoto breast cancer consensus conference on this topic. The panel voted actually not 15 millimeter, there was a conservative. The majority voted for 1 centimeter cut. And also another important issue would be biopsy. As you can imagine, the radiofrequency ablation after no tumor remains. So that we don't have any pathological assessment. That means the biopsy, core biopsy, will be crucial to understand the tumor characteristics. So that's we recommend to have the large size, the vacuum assisted, as many as possible, the number of the cores. In terms of the drug treatment, the more similar, presumably, the recent 10 years, many drugs have been approved in also in Japan. So 10 years ago, it was very tumor subtype specific. But nowadays, somehow, subtype non-specific, the drug development is ongoing in also Japan, such as the PARP inhibitor and also TDXD. I have been involved in clinical development of TDXD. So this is a publication from Daiichi Sankyo company. And as you know, the top one inhibitor, it's a DNA damaging agent, is a payload of TDXD. Left-hand side, it's a superiority compared with the antibody alone. Right-hand side showing that the TDXD may be better than TDM1 in many cancer cell lines. And this is a clear evidence that how the TDXD is superior to TDM1. Right-hand side, you can see it's almost no progression diseases on TDXD treatment. And the survival curves are quite impressive. And this is a very brief sketch on the summary of TDXD trials, the Destiny breast trials. And the blue is the HER2 positive. And red colors and letters are the neoadjuvant or adjuvant trials. In adjuvant situation, comparing the TDM1 Catherine style. And also we got the B11 trial, where neoadjuvant trials ongoing. And the yellow columns It's a HER2-low trials. Now we have the 3 or 4 trials. We conducted this trial. It's an old trial already, but we called the neopeaks, GBG-RG20, HER2 positive. The control, TCHP6. Test arms were TCHP4 followed by TDM1. So the cytotoxic chemotherapy followed by ADC. And third arm, TDM1 alone. But we checked the response. If residual disease, when identified on image or by biopsy, the protocol recommended to switch to the AC. And this is the outcome of our trial, stratification by estrogen receptor status. Group B, and particularly, the sample size is very small, but the Group B showed the PCR rates in estrogen receptor. As you know, the estrogen receptor positive, it's hard to get the high PCR rate. But in this trial, we could get about 70% PCR rate. This sequence may be interesting to have high PCR for estrogen receptor positive cases. On the right-hand side is if responded well to TDM1, high PCR rate around 70% could be estimated, but not responded well, only 30% PCR rate was achieved. So that's what will happen with TDXC. We are discussing a lot on this issue in Japan. HER2-low, it's another quite impressive trial they published in New England Journal of Medicine. They're comparing the physician's choice treatment, the TDXD, very effective seems to be. Now, maybe this afternoon or tomorrow, I don't know, they will be discussed on this topic, HER2-low. Last August, maybe the ESMO, the consensus conference consensus statement was published in Annals of Oncology. I totally agree with the major comments. And this is another opinion from the DFGI Dana-Farber in Harvard. And they indicated the lowest or low border, how we can identify the ultra-low and HER2-low, or the HER2-0 and the HER2-low. That's a big issue. We are also discussing quite a lot on this issue in JBCS, Japan Breast Cancer Society. And the fourth issue, oral fluoropyrimidine imaging. And this is a very important case to me. The 2002, presumably, she was treated with a FEC followed by docetaxel, very old-fashioned mammogram, and the ultrasound. And what's amazing to me was she got the complete response after a FEC treatment, anthracycline. But after switching to docetaxel, the quickly tumors regrew. It grew, actually. Usually, we understand 10 years will be needed to get this size, 2 or 3 centimeter before treatment size. But after switching docetaxel, only 2 or 3 months allowed to grow like this. So this is an initiation case in my mind for CREATE-X trial. And we hypothesize this story. The anti-cancer drugs may be able to induce anti-tumor effects, but also induce pro-tumor effects. This might be indirect or direct in cancer cells or in stromal cells, the tumor microenvironment. This theory of the hypothesis was published in Nature Review Cancer many years ago. In the 90s, I characterized the primary breast tumors with old-fashioned technologies, ELISA or the immunohistochemistry, etc., etc., and they analyze the tumor microenvironment, how it is, and what happens after treatment with the multi-drug cytotoxic chemotherapy. And we found that these factors are clearly activated, upregulated, increased by treatment. Transcription factors, the NF-kappa B I mentioned, chemokines, MCP1, for example, enzymes, the COX-2, and also thymidine phosphorylase. This is a working hypothesis around 2003 or 4. And in Oxford, as already introduced, I spent 2 years in Oxford. I was involved in the thymidine phosphorylase, the research, TP. It's the salvage cycle nucleoside, the enzyme, metabolism enzyme. And the Adrian Harris and Roy Bicknell, they clarified, they characterized, identified how these right-hand side, the biochemical chain reactions are induced. Once upregulated, once switched on, just continue, straight forward, non-stop. And in tumor microenvironment, another positive feedback loop would exist. The thymidine phosphorylase is upregulated by stress, carcinogenesis, for instance, MYC, and also the inflammation, hypoxia, poor nutrition, and also chemotherapeutic stress. That is a very potent inducer of TP. Once upregulated in tumor microenvironment, it is continuously, such as the chronic inflammation. So on the other hand, in Japan, the pharmaceutical companies were interested in this molecule because, as you know, TP is a converting enzyme of capecitabine to 5-FU. So if TP is upregulated and we can give the capecitabine, what happens? So the pro-tumor reaction may be switched to the anti-tumor effect by capecitabine. And we could make the two scenarios. Obviously, everybody can make it the two fashions, concurrent combination with standard treatment or sequential treatment. And in Japan, we have a long history of oral fluoropyrimidine, oral 5-FU development in metastatic and also adjuvant setting. This is a summary of adjuvant trials. Actually, I started my career in 82, and the first trial, Asset BC01, started also 82. And I have been involved in all these studies, particularly Titan 3, I involved as a PI or the responsible or investigator. OOTR 003, concurrent use of capecitabine with ACO effect T. And unfortunately, we failed to demonstrate its survival impact. I don't know why, but the result was negative. And the potent, I will mention later, and the CREATE-X is a sequential use after neoadjuvant chemotherapy, then add or not of the capecitabine. Initially, I made this trial design. It's a very simple trial design. I proposed to companies, but companies refused because of the patent issue. And I asked Professor Ohashi, two issues actually, the drug itself and also the trial design itself. I wanted to focus on non-PCR cases, trials, but no trial has been conducted in the focus of non-PCR. We knew that the non-PCR cases are poor prognostic, but no trial was there. But Professor Ohashi is a great, talented biostatistician statistician at that time, the Tokyo University. And he supported us a lot, organizing the trial and also designing the trial. And the Professor Masu, the left-hand side, and the right-hand side, the Professor Sunjuri and Professor Yoon Suk-ri, they worked together in developing the trials and also the conducting the trials. This is well known. It's a New England Journal of Medicine paper, and they're showing that the capecitabine use after neoadjuvant treatment post-operatively should be effective, particularly triple-negative breast cancer. So that's the global guidelines. We took this outcome, and also we got the consensus to use the capecitabine in this fashion. But on the other hand, we are also interested in the luminal diseases, estrogen receptor positive, HER2 negative. Some trend we could see in this trial. And the recent, the EBC-TCG meta-analysis demonstrated that oral follow-up imaging, not only capecitabine, but also other 5-FU drugs, that seems to be effective, advantageous to get better survival outcomes, not only in TNBC, but also in luminal diseases. But it's not yet published. Another drug, it's S1, 57, my born age, my born year, Professor Heidelberger identified the 5-FU. And then the prodrugs, 3 prodrugs were discovered, and then UFT and S1. Now we have the 2 big in Japan. S1 is unique, 3-drug triplet, and increasing the efficacy and also reducing the GI toxicity. And potent trial is a very simple trial, the plus minus S1, Q3 regimen 2 weeks on, 1 week off, 1 year. And the control, just simple, on the standard endocrine treatment. Criteria was broad aspect, the intermediate or high-risk patients are possible to include node-negative cases. We have many. And outcomes are published in Lancet Oncology 2 years ago, I guess. And the dosage was individualized according to renal functions. And this was discovered in GI cancer treatment, the trials. And hazard ratio about 0.67. As I mentioned, we got about 30% or 30% node-negative cases. In the previous trials, we demonstrated that the UFT is equivalent with CMF in high-risk node-negative, grade 3 node-negative cases, for instance. So that we included the node-negative high risk. That's the 30%. And no neoadjuvant or adjuvant cytotoxic treatment, chemotherapy naive. S1 should be the first chemotherapeutic drugs. About 40% of the cases were like these. But in all these subpopulations, S1 seems to be positive, effective. As you know, we got the very impressive outcome on the abemaciclib. I have been deeply involved in monarch studies, metastatic, and also monarchy adjuvant trials. But this trial is very straightforward. Looking at very high risk, anatomical high risk, and pathologically high risk. And the 2 years treatment. That's really nice. And also we confirmed 2 years, the carryover effect after cessation of abemaciclib 2 years. So it looks very promising. But in practice in Japan, we have the S1 and the abemaciclib, how we can differentiate it. That's a big issue. These 2 years we discuss a lot. So Professor Takada conducted this retrospective analysis of prospect trials, the potent S1. Just so simple, focused on the cases fulfilling the monarchy criteria, very high risk. And that is the upper side, is the overall outcome. The S1 seems to be positive. But in this particular subgroup analysis, no statistically significant finding was obtained. But the bottom, it's a breakdown to over 4 nodes or 1 to 3 nodes. Over 4 nodes, and it's not very positive, unfortunately, but 1 to 3 nodes seems to be quite positive. And node negative may be positive, and 1 to 3 node positive. So that is the current situation in Japan. Very high-risk cases are treated by abemaciclib, node negative high-risk treated by S1, and between intermediate, and either possible. Maybe combination also possible, treated by S1 followed by abemaciclib or inverse sequence. And also, Professor Takada created the very simple Kyoto University risk score. He made a composite risk model by using very simple clinical or pathological parameters, the tumor size, and nodal status, positive, negative estrogen receptor, 9% or over 10, and grade 1 to 3, and also the Ki67, less than 14 or over 30%, 3 categories. Very simply and quickly calculated, and also provide us which category, grade, group 1, low risk, group 2, the intermediate, grade 3. Group 3 is a high risk. If group 2, we can say this S1 efficacy expected. Okay, the age, I'm sorry, it's before lunchtime. We say these teas and soybeans would be good for health and maybe preventive for many diseases, including malignancy. So, thank you very much. Again, together with Professor Ohashi, we designed this epidemiological study. We want to analyze how the soybeans important. Also, we paid attention to the Yakult, maybe you know the Yakult, and the probiotic beverage, and they discovered in Japan in Kyoto University many years ago after Second World War. And we got the Yakult, the home delivery system. 30 years ago, for example, we didn't have any other the probiotic beverage except the Yakult. It was very simple. And also, Yakult company created the home delivery system many years. Once started, continue for years. That's the style in Japan. So that's the Professor Ohashi, they paid attention to the particular Japanese domestic rule, and analyzed how it is important for preventing breast cancer in case control study. X-axis is a quartile, 4 quartiles of soybean intake. The y-axis is the probiotic beverage intake, the frequency. But the important thing is how long we can continuously intake these products. And anyhow, the combination, soy isoflavone and the probiotics Yakult seems to be effective for preventing about half in this epidemiological study. So it was impressive to me. But recently, we conducted this molecular analysis, particularly focusing on evolutionary history of breast cancer and related clones published in Nature last year. It's a collaboration study with Professor Seishi Ogawa, tumor biology of Kyoto University, and other expertise, such as the organoid expertise, and also pathologists. Initially, we looked at the relationship between age and accumulated gene mutations. And obviously, it is not easy to get the normal breast epithelial cells from healthy ladies. So that Professor Ogawa created an idea that we should culture organoids from milk, breastfeeding milk, and is screened by the epithelial markers, and they made organoids. Actually, the 64 single-cell derived organoids were made in this study from 6 healthy volunteers. And also, we take the tumor samples from normal, pathologically normal, and the breast ducts from 6 the premenopausa and 9 postmenopausa, and looked at the single nucleotide variants, SNV, for instance, SBS1, which is known to be TC nucleoside, the rich the variant, and the SBS5, or etc. And you can see the very straight the relationship between age. Age is a risk for getting the mutations. Now, according to the linear regression model, the number of SNVs depends on age, years, or after menarche, and parity, quite interesting, and the presence of the driver mutation such as the PIK3CA. According to the calculation, about 20 mutants per genome per year before menopause. After menopause, it's a curve change to about 10 mutants per genome per year. And quite interesting to us, the mutant number was reduced by 55 mutants per genome per delivery. So delivery can reduce the mutation numbers. It's quite amazing for us. And PIK3CA, this is estimated, increase the number of SNVs by 210. It's jumping up. Second issue is the first author, Tomomi Nishimura, conducted this fine analysis. It's very complicated. It's really tough research. But together with the pathologist, they did this microdissection analysis. Pathologists first defined the lesions, and also they made a diagnosis for each small, tiny lesions. And then the Dr. Nishimura and the Professor Ogawa's group conducted the molecular analysis using, for instance, NGS, or et cetera, et cetera. And for example, just the middle, the tumor, how the chromosome 116, the abnormality clones, and expanded in the breast tumor tissue. And also phylogenetic, the tree analysis was made to calculate the time to get the abnormality and the time to get the some clonal expansion. Bottom is the 116 chromosomal, the abnormality, the testing with the fish analysis. And mostly these cases were luminal ray-like tumors, invasive ductal, and also invasive lobular. And the tumor samples were from the 40s and the premenopausal women breast cancer cases. On the left-hand side, what we found was the initiation issue would be chromosomal abnormality such as DA116. It's really early event, around 10 years. Even less than 10 years, the old 15 puberty, early puberty time, this may happen. And later, the around 25 to 30, MRCA, common ancestor, will emerge. So it's a very long-term event in the history. After that, the subclonal expansion will be developed for many years' time. For instance, the bottom case, actually, they developed 75 years old time, the cancer developed. So that means 50 years to get the cancerless subclones. And also we identified how the subclones are heterogeneous. This might be an issue to understand the heterogeneity of these, the luminary and invasive lobular cancers. This is a hypothesis-making basic science, but it can bring us an insight to understand breast cancer biology, natural history, and also it would be important for considering prevention, screening, early detection, and maybe for treatment as well. So now these technological advances in these 30 years' time, 90s, just simple molecular analysis were possible. Around 2000, we got the ctDNA-based chip analysis or the array analysis, or genomic assays were developed. These 10 years after NGS, many new technologies, and we are able to analyze in various ways that help us to understand breast cancer more. Vielen Dank. Thank you very much.
Arigato gozaimasu. Thank you very much for this excellent lecture and for this, travel to the microenvironment, to the tumor heterogeneity. So thank you very much for coming to Frankfurt, to Germany, and this should remember you on Frankfurt. Thank you.
Thank you very much.
Yeah, this looks like Easter eggs. No, we don't discuss keynote lectures. You can speak during the lunchtime. So, Herr Overkamp, ich glaube, wir machen Päuschen, oder?
Genau, dann würde ich vorschlagen, dass wir vielleicht bis 14 Uhr Pause machen. Ich wünsche Ihnen allen guten Appetit und dann sehen wir uns zum zweiten Teil. Danke.